All right, welcome everyone. Today we're going to talk about wound healing and how that relates to our surgical procedures and what we do as technicians, and then also surgical suture material and suture patterns. And when we get back to class, we will practice using these different suture patterns, but we absolutely do need to know the different types of material, when they'll be used, and I also got some questions on my VTT about when to use certain suture patterns. So even though in the state of Arizona that's not usually within our standard of practice or our scope of practice, it is something you may need to know for that purpose, or in some states like California for instance, we are able to suture legally. All right, so we'll begin with wound healing. It's important to remember that surgical incisions are wounds. Of course, we deal with many other types of wounds also, like dog bite wounds or abscesses that have formed. But our surgical incisions as well need to be treated and thought of as a wound that needs to heal. So we're going to look at how that normal healing process happens and how we can make that happen faster, better, or how what we do might actually interfere. All right, so a wound is anytime we have that disruption of tissue. Normally we think of that disruption of skin, but of course if I'm making an abdominal incision, I'm also disrupting the connective tissue, possibly the muscle, and then whatever organ I've cut into as well. So we do need to consider healing for all of those parts of the body. We've got 4 basic phases for healing here, and sometimes in the textbooks you'll see them broken up slightly differently, but they're always going to be the same basic phases. They may just have slightly different names. All right, so we've got wound healing here. I would encourage you to go ahead and watch that wound healing video that's in the YouTube playlist that'll go over this process. But we always start with inflammation. Inflammation is when we get vasodilation in the area that needs to heal. That vasodilation brings macrophages and nutrients and more oxygen to the area that needs those resources to heal. So clinically, that's what we see as the redness or the swelling or edema that's in that location. Sometimes this may even look like pus. If we have, let's say, a lot of debris in the wound during the inflammatory phase, we also get what we call debridement. And debridement's going to be those white blood cells, those macrophages coming in and removing the hair that we've gotten in there, or the dirt, or just simply the dead tissue that's in that area there. So those 2 phases together, inflammatory and debridement, are referred to as the lag phase. And the lag phase is very important for us as technicians, because things like the steps we take to ensure asepsis are going to shorten the lag phase. It's also notable that, let's say we have a really contaminated wound, or we have a lot of trauma where the body has to do a lot of debridement, let's say, then a lag phase might be longer. And what that's going to mean is that it takes longer before we get into a repair phase or a maturation phase. So for example, if I have a really contaminated wound that I need sutures removed from in 10 to 14 days, it's possible that they won't be ready to come out at that point because my lag phase has been so much longer than normal. So after we are done cleaning things up, we get into our repair or proliferative phase, and this is where new tissue cells come in. Fibroblasts are the name of those new cells, and they will lay down kind of a scaffolding tissue, and then eventually that's going to get filled in through maturation there. And maturation can take several years. It's never going to be as strong in that area as it was when we had the original tissue in place, but over the course of a couple of years, hopefully we'll be able to restore most of that integrity. All right, so I mentioned that there are things that we can do that affect how quickly a wound or a surgical incision heals, and then there's also factors that we may not be able to control, but we can still anticipate that they may slow healing. So older patients, oftentimes geriatric patients, will take longer to heal. If I don't have enough resources in my body, things like protein because I'm malnourished, that's going to extend healing time. Certainly patients that are not healthy in general. We've talked about the immune system as having just a limited number of soldiers. If they're dealing with some other organ failure or issue in their body, or they have multiple wounds to be healed, that will take longer. And then if we're taking any kind of corticosteroids, so that's drugs like our prednisone or prednisolone or chemotherapeutic agents that delay cell regeneration and proliferation, that's going to slow down wound healing as well. All right, what's going on inside of the wound or the type of wound we have will also extend or change this lag phase for us. As I said, if there's a lot of foreign material or dirt, then that debridement phase where we're going to have to remove that material is going to take longer so that the body is able to do that. We can sometimes speed this along by doing things like flushing or removing or cutting away dead tissue before we allow the wound to start healing, so we can certainly have an impact there. The type of incision, if the incision's in a place where there's a lot of movement or maybe we're not able to completely bring those edges together, that's going to require longer. It's kind of like we're building a bridge between those two sides, and if those two sides keep moving in relation to one another, the bridge we're building is going to get disrupted as we go. As I said, if you've got pathogens or infections in that area, not just dirt, but let's say I've got something else the immune system has to take care of, the body's going to do that first as part of that lag phase before we get to repair. So if we do suspect something like bacteria, we'll start antibiotics to try to speed things along. And then sometimes we have wounds where we're not sure if the tissue is getting adequate blood supply. One example occurs with little dogs. They sometimes get picked up by owls, and when they do, that skin at the back of their neck or on their back where the owl grasps them with the talons is pulled away from their body, and that may tear or damage some of those blood vessels that bring fresh oxygen and macrophages to the site, and in that case that tissue may take longer to heal, or it may not heal at all. It may eventually die, so blood supply is a factor too. All right, other factors we may look at, we've already talked about corticosteroids, we said chemotherapeutics, cancer drugs, because they're designed to target cell division and slow it of the cancer cells. They're also going to have that effect on regeneration or healing. Now, anti-inflammatory drugs, so this is your Rimadyl, your Theramax, your Onsor, these will also slightly delay healing because they do suppress that inflammatory phase, so we don't get things like swelling and pain and redness in that area, but that inflammation has a purpose. So we do make a trade-off for most patients, knowing that in a healthy and a normal patient, maybe we will extend that lag phase just very slightly with something like Rimadyl. We decide that not having that patient in pain is worth it, but it is something that you always have to keep in mind. All right, so let's say I get a wound coming in. One of the things I'm going to ask you to do this week is to find a case study of a wound that has occurred in some kind of an animal and tell me how it happened and what it looks like and so forth. We see all kinds of things. I think of things like dogs who jump through windows, or cats who get their tails caught on fences or doors, and they kind of rip part of the tail off. Obviously, we see a lot of animal attacks on one another, and that's probably the primary case where we see this. But when we have a wound come in that's open, if we can, we always want to minimize contamination that can occur. There's always been some, but hopefully we can shorten that lag phase by not contributing to it. So if we can cover a wound initially with a clean, dry bandage, something that's not going to stick to the wound, that's ideal. If it's not in a great location for that, another option, and something we might do even in addition to that bandage, is put in a little bit of a lubricant. That Sterilube in the little packets works really well for this. We don't often use antibiotic ointments. Your textbook says so. We want to avoid things like creams and powders. We want something more that's an ointment or a water-based lubricant to block the pathogens from getting inside, and also things like dust and hair. Sugar and honey we'll get to talking about a little bit further here, but sometimes those are used as something that we can put topically on a wound later in healing, because they do draw water out of the tissue, and they also actually have some effects to halt bacterial growth, which is a little crazy to think about, but they do help us do both of those things as well. All right, once we've covered the wound and the doctor has evaluated it, the next step is typically to lavage or clean a wound. If the wound is not very big, the patient may be awake for this. It's not typically painful, it feels weird, but If we use solutions that aren't too acidic, then most of the time they don't mind too much. If it's a large wound or we need to do this for a long period of time, then we may anesthetize the patient for this. So wound lavage is done to, again, shorten that lag phase, so we're removing debris and particles and bacteria. If you have, though, a really big wound and they just come in covered with mud, I don't need to stand there with a little syringe of saline and spray off the mud. At that point, the damage has been done. Let's just get them into the sink and give them a bath, and then we can go back with sterile solutions and kind of clean further, but use common sense with this stuff. We don't typically add any disinfectants. Most of the disinfectants, even dilute iodine and chlorhexidine, can irritate the tissues, which is going to extend that inflammatory phase. And for the most part, those aren't necessary or helpful when they look at the research. We do get an added benefit of the pressure that we use with lavage. So using a syringe or the setup I'm going to show you here in a second helps us also to just push out any of that debris or possibly pathogens. So that mechanical action is an important part of this. Most of the time we don't just want to be pouring solutions on. We want to be kind of pressure washing, if you think about it that way. So this is a real common setup that's pretty helpful. We've got our bag of fluids here. In this case, they've got Normasol. Lactated ringer is the one that tends to be tolerated best by patients because it's not as acidic as either the Normasol or the saline solution, so that's what we tend to use the most. You've got a normal fluid administration set here and then a three-way stopcock. And that three-way stopcock will allow you to hook up a syringe. 35 milliliter is the preferred here. It's supposed to generate the right amount of pressure when combined with an 18 gauge needle or 18 gauge catheter. And without disconnecting anything with the three-way stopcock, you're able to pull fluid through the line and then turn that little stopcock off to the bag and then push fluid through the needle. And that allows you to reduce the contamination you would get if you had a syringe where you were constantly disconnecting and having to draw from the bag. So wound lavage is important, but another way that we can reduce the lag phase is debridement. Sometimes in videos you'll hear them say debridement, which is what is the pronunciation in human medicine, but veterinary medicine we universally say debridement. We do this so that the macrophages don't have to do this work. We will have less of that time spent with them removing dead tissues or other material if we can get it out of there for them. That's our whole goal with all this stuff. So you've probably seen something called en-bloc debridement. En-bloc debridement is when the doctor just surgically excises the tissue. Sometimes they call this freshening the edges. There's a Vet Ranch video I've got in the playlist that I'd like you to take a look at where he takes a scalpel blade and he just scrapes the actual tissue off and takes a layer off, and that would be considered debridement as well. They do make enzymatic powders, and these are much more commonly used in large animal or equine medicine, and those you kind of pack into the wound and they dissolve away, eat away some of the tissue, and then we have fresh, clean tissue in that spot. Now, honey and sugar can be used, especially if we have large open wounds that we don't anticipate being able to close right away. They're hypertonic and they're osmotic. And both of those things mean that they're going to draw water from the wound, and along with water, discharge and bacteria. And so they do seem to act as solutions or substances that will help to debride the area. Even though sugar or honey seems like food for bacteria, and it certainly can be, it can also have properties that prevents the bacteria from being able to do their things when it's in a high concentration like that. So when these bandages are put on, typically we'll pack honey or sugar into the wound. We'll put a wet to dry bandage. So we'll put some gauze that is saturated with a sterile solution like saline on top of that honey or sugar in the wound, and then dry gauze over it. And we might change that every day because it is going to pull discharge and fluid and gross stuff out of the wound. So we wouldn't want to let it just sit there and grow into whatever it's going to grow into. All right, so in a perfect world, we'd be able to close wounds by primary wound closure. And primary wound closure is when we're able to bring the two edges together. They call that apposition. So apposition with an A, appositional healing. So this is what we get when we do a surgical procedure and we suture that wound shut right away. That's appositional healing because it's primary wound closure, and that type of healing is also going to be referred to as first intention. I always think about this as it's the first thing we want to do. It's the best thing we want to do. If possible, that's always going to be our goal. Now, primary wound closure has to be done within the first 6 to 8 hours after the incision or the wound has been made to consider it primary wound closure. And that's going to give us the least amount of contamination, hopefully, and shorten that lag phase. We can do this when there's been minimal trauma. If we think there has been a lot of, let's say, loss of blood supply to the tissue, this may not be our goal. We may leave things open for a couple days and wait and see before we close things. But this is always the best case scenario, and it's always going to result in the fastest healing with the shortest lag phase. Right, so delayed primary wound closure, this is when we're able to still get that appositional healing, so we're still bringing the edges together. This is still considered first intention healing because it's still going to be faster than any of our other options except for primary wound closure. And this is when we're a few days out after the injury, but before any tissue repair has been able to occur. So this might be used in situations where, as I mentioned, we have some tissue that we think may die, so we don't want to close things until we know for sure. And this is typically used for wounds that are mildly traumatized. So we may want to, let's say, leave it open for a day or two after we clean to make sure that we've kind of gotten everything, no abscesses forming, because we don't want to close things and then have a big pocket of pus fill that area and kind of disrupt the work that we've done. Second intention healing is the type of healing where we leave the wound open until it heals on its own. And I always think about this as having to fill the empty space from the bottom up. So with wounds that are left open, you'll see contraction of the tissues. It may look like a pucker in the skin around the wound, and then we get the epithelial cells filling in that space. That tissue that's formed by epithelialization is called granulation tissue, and it's pink and delicate, and it may bleed easily. This type of healing is definitely going to take the longest, so this is our least favorite option. But if we have a wound where, let's say, we've had to remove a cancerous tumor and we don't have enough skin left to close the area, we may have to resort to second intention healing. And we do have options like our wound vac that we'll look at that may help us heal a little bit faster, because the concern here is that in leaving a wound like this open, at any point we can contaminate the wound again, pathogens can grow, and that can lead to things like sepsis. So this may also be a situation where you're using a sugar or honey bandage or doing regular bandage changes just to help prevent that from happening. We do this also, and you've probably seen with situations like abscesses. With an abscess, we've got a pocket formed in that tissue, and we refer to that pocket as dead space. This is a different kind of dead space than what we've talked to you about in the airway, but tissue dead space where the top and bottom layers aren't together. We've got that space there where there was a pathogen. The white blood cells have come in, mainly neutrophils, to clear out that pathogen, and in that process we've created separation. So there's a lack of apposition. And because of that lack of apposition, if we just, let's say, left it as it were, it would take a long time to heal. The body would have to reabsorb all of those white blood cells before it could move on to actually healing. So we speed that process along by putting an opening there and draining out the pus, and then we leave that opening so that if more macrophages come to the site, they'll be able to leave readily, and that way we're maintaining apposition not between two sides of a wound, but between, say, the skin and the fascia and muscle underneath, between the top and bottom. So that's another time that we might employ this technique. Now, third intention healing, you guys already know what does 2 + 1 equal? It equals 3. So third intention healing is a combination of second intention and first intention healing. We do this when we do have a large area that's open that we can't initially suture, either because it's too contaminated, because we're not sure if the tissue is going to live. So if we go ahead and put sutures in, the tissue may be on the road to dying anyway, and we've just wasted our time. Or when we have such a large area, let's say that we're concerned that if we went with second intention healing, it would take months and months to heal, and during that time the patient might acquire an infection. So we'll see this pretty commonly with things like you might have, let's say, a surgery on your elbow or knee, somewhere that's moving, and they're not able to completely remove, or I'm sorry, they're not able to completely close that area without pulling on the skin and causing those sutures to come out. So we might leave it open for a few days at least, and then go back once some of the tissue's been able to heal and it's come a little closer together, and then suture it the rest of the way. So we're going to leave the wound open for at least a few days, sometimes a few weeks, depending on what we need to do. And then as soon as we can, we're going to go ahead and close that wound. And this will be faster than if we left it for second intention healing alone, but not as fast if we were able to achieve first intention healing. So how do we decide how we're going to close a wound? Definitely depends on how long it's been since the injury. If the wound has already started to form granulation tissue, it may not be beneficial or helpful to go back and disrupt that to do a primary or delayed secondary wound closure and first intention healing. Again, if we have a lot of contamination and we're concerned the body's going to bring a lot of neutrophils to that site and they're going to collect there, we may leave things open so once the neutrophils come and do their job, they can easily leave. We've talked about if there's a lot of tissue damage or we're not able to truly anticipate how much debridement needs to be done. We may wait a few days and kind of see how things go, which tissue lives or dies. And then the animal's health. We're always going to go for first intention closure, but if that's not going well, sometimes we have to come up with another strategy. Tension and dead space are a big issue too. So as I used in my elbow example, if we do have an area where the patient's going to be pulling on those sutures or the wound's going to be moving, we may decide not to attempt a primary wound closure and go with something like third intention for that. Okay, so drain placement. I've got a video on Penrose drain placement I'd like you to watch. Penrose drains are simply open tubes of rubber material. You could really use anything to do this. There's not anything special about the tubing except that it is sterile and it's inert, so the body's going to ignore it. And we're going to use this as a means of keeping an opening into an area that we're concerned about having dead space. So again, those contaminated wounds will bring to the site a lot of macrophages, and then they fill in the little gaps in the tissue trying to get rid of the pathogens there, and then they get stuck there. They've come out of circulation and they're stuck, and they just have to hang around until they break down, and that's what we call an abscess. And as long as they hang around and they keep that lack of apposition, they keep that top and bottom tissue layer separate, the tissue can't begin to heal. And if we just go ahead and poke a hole and drain your abscess, the little neutrophils will be able to get out and we'll have apposition, but that little hole we poke may only stay open for a day or two. The body's pretty good at closing those. So drains are put in place when we anticipate a lot of debridement done by the body, and we want that opening to stay for more than a day or two. So drains will typically put in for 3 to 5 days, and we will remove them at that point, because if everything's gone well on our little graph of healing, at that point we'll start to get repair. So if we leave the drain in longer than that, we'll see that the tissue may start to heal to the drain, and of course that's not our goal. So Penrose drains are an example of a passive drain. They rely on gravity alone, so when we place them, we want to make sure that they are anatomically placed in such a way that gravity will be able to aid their flow. So when the patient's standing, it's pointing towards the ground, for example. We will put these in place usually after closing the original wound. We'll create a new hole or a new opening because that allows the body to kind of do the hard work on the wound. It'll be able to close up this nice clean incision we made much more easily than that. There's a lot of different techniques to put these in, but the result should be that we do get discharge or flow around the drain. It doesn't necessarily go through the lumen of the drain. It's just going to go around, and then we may have the clients at home do things like warm compressing, where they take a warm wet washcloth and just clean any discharge around the drain, because we do need this to be patent. We need it to be open to allow any of those white blood cells to flow out or other fluid, and to keep tissue apposition. That's going to be our goal here. We do have another type of drain that we use commonly, and those are Jackson-Pratt drains. The Penrose drains leave an opening in the tissue to the outside. So They are going to be useful in situations where I have damage to skin or muscle, but they may not be so desirable if, let's say, I need a drain in the body cavity because I don't want a big hole from my body cavity to the outside with nothing protecting it. They're open. Those Penrose drains are just going to get fluid everywhere potentially. So Jackson-Pratt drains are a nice alternative because they are a closed system, and they can be placed into a body cavity or into a much larger area. They have a drainage end or paddle or sometimes holes within the flexible tubing that can be, let's say, worked under a larger area in a wound and allow me to get drainage from that entire area without having to place multiple drains. So that's kind of helpful for these guys. And of course, in something like my thorax, I wouldn't want to place just an open hole with a Penrose drain. So Jackson-Pratts are great for those body cavities and for larger wounds as well. They do have a collection set we call the bulb, or sometimes is called the grenade. And I want you to go ahead and watch the video I have in the playlist for how to handle these grenades. I have these at school for us to use as well. These bulbs will provide active suction. So Jackson-Pratt is an active drain. I can go ahead and compress it down so there's no air in it, and I can push down that stopper, and then the bulb is going to try to suck air through those little holes or fluid or whatever it can, and it'll fill itself up in the process. So I get better tissue apposition with the Jackson-Pratt because of that active suction process, and I also am able to see and quantify and possibly cytologically examine what's coming out of the wound. So that makes it easier for me to know how wound healing is going. Now, disadvantages may be that clients do have to empty this if you send them home with it. They have to learn to empty the grenade. You can do that through the stopper, and then they have to learn to squeeze and put the little tab back in. But it's pretty straightforward, and it ends up being more aseptic for us as well. I've included a video on vacuum-assisted wound closure, or sometimes we just call these wound vacs. These are something that have been used in human medicine for a while for open wounds, especially things like bed sores, where it's not particularly feasible to just close the tissue, or where there may not be two good sides to create apposition. These we rent from healthcare supply companies. Hospitals usually don't keep them around. But what they do is they contain a sponge-like dressing, and it's just a black material that you actually put into the hole, and then you put this sticky saran wrap over the wound and over that they call it granulofoam dressing, and that attaches then to suction tubing, and the suction pulls on the sponge-like material, and that pull will pull fluid out of the wound, so it drains the wound, and that tension on the cells also encourages them to grow faster, so you get faster wound healing as a result. Another advantage here for a big wound is that you're going to keep the wound covered and very, very clean through this process, and so that reduces the chance that you're going to have something like sepsis. So this is a great choice when you're going for third intention healing with a really big wound, so I want to be able to close it, but I don't have enough tissue there to do it yet. So take a look at that video. The little tubing is hooked up to a pump because it does pull continuously, so it's an active suction system, and it comes with a little backpack that the dogs can wear that is going to carry that pump around. It'll run 24 hours a day with a little collection cartridge that the clients will change out at home. If they're really small and they can't wear the little backpack, we could also just kennel them for that period of time. But this may be on for a week or two to allow the wound to heal to a point where we can go back and do that surgical or third intention healing. Before we move on to suture material, needles, patterns, take a look at the maggot therapy video that I've included for wound care. That's another option for debridement, and it's one of my favorites, so I'll make sure to ask you about that one in class. When it comes to suture needles, we can buy needles already attached to the suture, or they can be reusable needles or individually wrapped needles, single use only. So they do vary by how they're attached. They're going to vary by the shape of the needle itself, and that's going to depend on where we're planning to use it in the body. Then the point of the needle or tip and of course the size of the needle. So the size will once again depend on where we're planning to use it. We typically use larger sizes for larger animals, smaller sizes for smaller animals or smaller wounds that we're closing. Now, as far as the shape goes, we're referring to what part of the circle they take up. So a half circle, as you can see there, is going to be taking up half the diameter of a circle. We have a quarter or 3/8. Quarter circle needles are very small and usually only used for things like ophthalmic or vascular surgery. But the reason that we like to use these curved needles is that we want to follow what they call a curvilinear path through the tissue. So I picture the Grand Canyon. If I wanted to drill down on one side and go through the middle and kind of come up through the other side of the Grand Canyon, then the best way to do that would be to kind of follow a curve. And so that's what your suture needle does, is it follows a curve to bring those two canyons together. If you tried to do the same thing with a straight needle, then you would have to go at an extreme angle down one side of the tissue and then an extreme angle back up through the other side, and that wouldn't be helpful. We would do more damage in that process. So that's why the needles are curved. We do sometimes still have straight needles available for things like suturing skin. I use them sometimes for suturing urinary catheters in place or central lines, but otherwise we're going to use these curved needles. Most of the needles we use at this point are what they call eyeless or swagged-on needles, and these swag needles are manufactured so they're attached to the suture material. This is great for us because they have a very small attachment, so they don't have a big eye that has to be pulled through the tissue, and of course they are single use only because they are attached to that suture, so we don't have to waste time putting them on or cleaning them. So that's what you're going to see most commonly now. There are closed eye needles out there that just looks like your standard sewing needle or French eye, where you pull the material down through into the eye through those little openings, and either one of those can be reused. So we purchase those sometimes for practice, but some practices, especially high volume practices, may use those as well to save on costs. But they do a little bit more trauma to the tissue, and they do take a little more surgical time since we have to put the suture through the eye each time we want to use it. The tip or the point of the needle depends on where we're using it. So if you look at your suture packages, you'll see that they are labeled for this type of tip. The taper needle has a blunt point, and not only is that point blunt, but the body of the needle itself, the curvature, is not sharp. And so this is going to be used in areas where we're dealing with really delicate tissues and especially hollow organs. So hollow organs like your let's say your bladder or your stomach. If we have a sharp edge on our suture needle, it's possible that when we pull it through, we're going to actually tear that tissue. So that's what the taper needles are useful for. Now the downside is they're going to get dull very quickly because I'm relying on that point of the needle. The body of the needle, the curvature, is blunt, and so it can be hard to pull through things like skin after a few passes. Now the cutting needles are going to be better for skin or tough tissues, connective tissues, because not only do they have a sharp point, if you look at the conventional cutting needle, the sharp point will be on the inner surface of the needle. On a reverse cutting needle, the sharp surface will be the outside, so kind of the bottom of the triangle that's pictured there. The outside of the needle will be sharp, and that way when I pull it through the tissues, it's not just the point of the needle doing the work, the entire body of the needle is helping me to pull it through skin or through connective tissue. So probably the most common we see in practice are reverse cutting needles because they're pretty versatile for all those purposes, and they do a little less tissue trauma than conventional cutting. So that's going to be what I use for most situations. Suture material is available in a lot of different types, and we're going to choose those types based on the area that we're using it in. So of course our goal with it is always to make sure that the edges of a wound will hold together and that we're closing any open space or dead space where we could get an excess of fluid or macrophages building up there. Sometimes we do have specialized sutures that we'll see for things like our ACL repairs that are meant to be in long term. And we also use it for ligation or the closing off of blood vessels as we're cutting and removing tissue from the body as well. So we're going to choose our suture material based on its job. Keep in mind that if we, let's say, use a suture material that's never going to go away, that's non-absorbable, that could be irritating or unpleasant for the body to have to deal with. And so we need something that's going to last for as long as it can to allow the body to heal without causing a problem or without staying in longer than it needs to. A little bit of review here. Suture sizes run from larger diameters, which are our whole numbers, down to our 2/0, 3/0, 4/0, 5/0, which you can think of as being like negative numbers. They're going to be smaller. So 0 is kind of the baseline. We say 0 instead of 0. I don't know why, that's just how it is. From 0 or from 0 suture, it gets bigger. So 1 is bigger than 0, 2 is bigger than 1. When we go in the other direction, they get smaller. So 3/0 is going to be smaller than 2/0. Again, think of them like negative numbers there. So we're going to choose a diameter that allows us to have the most tensile strength, or the one that gives us the tensile strength that we need. Tensile strength is like the rope in tug of war. How hard do you pull it before it breaks? So larger diameter, we're going to have more tensile strength. If you or I take a rope and stand on either side and pull it, has a lot of tensile strength, we can't break it. But if you and I took a piece of roll gauze and we both pulled, chances are we could break it if we work hard enough, because it has less tensile strength. It's related to diameter. Now, the disadvantage of larger diameter suture is the knot security. So as the suture gets larger in diameter, we see a decrease in how well it will hold those knots that are tied. So if I tie 5/0 suture, which is very fine, into a knot, I'm never going to be able to untie that. It's going to be so difficult to get untied. But something like 3 or 4 suture, I can probably pull that loose. I can probably get that untied. So we have to balance those two considerations. Tensile strength is going to be more, larger diameter. Knot security is going to be less as the suture size increases. As I said, the packaging will show you what suture and what type of needle that you're using. It'll typically specify both a brand name and a generic name, and we're going to try to learn both. You'll see that we also say what shape our needle is. So this one here is a half circle. There is a point type taper in this case, and needle length as well. So I can have half circle taper needles that are 17 millimeters or 24 millimeters or 30 millimeters. More millimeters would just mean a larger needle, like I might want to use for a larger patient. The suture size or diameter will be listed there as well. So you're able to tell what you're using. Suture length, those tend to be pretty standardized. So typically I'll ask the doctor what type of suture material, what size, and what type of needle, and that's generally the most we're able to specify. We're not going to keep a bunch of different lengths on hand, let's say. Now, suture material is relatively delicate, so suture material is usually going to be sterilized by radiation. Ethylene oxide and steam sterilization will both damage suture to a degree, depending on the type of material. So this is not the kind of thing, I'll tell you, I eat expired dairy products, yogurt, I can't tell the difference, I'm totally fine, but I will not use expired suture. Even my veterinarian friends who, let's say, go and travel abroad to places like Colombia, and they do spays and neuters and other types of procedures, they will not take expired suture material with them because it does not hold up well. That also goes for reusing suture. There's not a great way. I've seen clinics take suture and put it in cold sterilization solution, the glutaraldehyde, and it damages the suture. It increases the chance you're just going to have, the patient's organs fall out. So it's not worth the additional risk, and you do want to take note of those expiration dates. Suture material is going to be classified in a few different ways. The first classification is natural versus synthetic. So a natural material is made from some type of animal product. Silk, for example, is made by insects. The catgut we're going to look at is made by taking the intestines of sheep or goats or cows and forming that into a material. Synthetic suture is some kind of polymer. It's some kind of plastic. Now, we also do have metallic or stainless steel sutures that are sometimes placed in their own category, but I tend to think of these as synthetic as well. Now, natural sutures in general incite more of an inflammatory response in the body. And for a long time, we used these preferentially for that reason, because we thought more inflammation is good. But if you remember what we talked about a few minutes ago with wound healing, more inflammation is going to increase our lag phase. So while inflammation does tell us that the body's paying attention to the area, it actually is going to extend healing time. So it's less common to see these natural sutures used today, and for the most part we rely on synthetic material. The next classification is monofilament or multifilament. So multifilament sutures are braided suture. Monofilaments are going to be a single strand. Monofilament is going to have the least amount of drag through the tissue. It's going to go through the easiest, and therefore it does the least damage to those tissues. It's also pretty hard for bacteria to climb up, let's say, because it's slippery for the bacteria. And so it's a very popular choice for abdominal surgeries and skin. Most of the time we do use monofilament for general surgeries like spays and neuters. Multifilaments have some advantages. They do hold knots a little bit better. Instead of being one slippery strand, they're braided, and the knots can kind of hold on themselves, which is useful in certain applications. They do cause more drag. They've got those little ridges from the braiding that pulls through the tissue, and we also see that bacteria are a little bit better at getting in those crevices of the braids, and so most of the multifilament suture you'll see will be coated with an antibacterial coating for that reason. Now the last classification is absorbable versus non-absorbable suture. Absorbable is suture that begins to lose tensile strength, so tug-of-war strength, within 60 days. That does not mean it's going to be gone within 60 days. Most absorbable suture will not be, but it will be starting to be weaker within 60 days or less. We can certainly see that if you have a fever, or the area is very moist, or infection is present and there's a lot of inflammation, then this may break down a lot sooner. Now, non-absorbable suture is used in situations like our knee repair that we talked about, where maybe we want the suture to last forever to stabilize the joint. And we also use it in places like for cosmetic surgery or external placement like drains, where we're not expecting to leave it in for a long period of time, but we want the body to ignore it. It's relatively inert, and we want the body just to say, I don't care about what's going on there, and not generate an inflammatory response. So that makes it a good choice for a cosmetic result, and also when we're planning to leave things in. If we place non-absorbable suture externally, we've got to take it out. If we put it in a body cavity, we have to know it's going to be there forever, and that has to be what we want to have happen. Alright, so synthetic absorbable monofilament is the most common type of suture that we use in small animal medicine. It's almost always packaged individually with the needle already swagged on. And these different types of sutures are used based on how quickly they're going to absorb in the body. So polygocaprone is monocryl or monosin. Those are some common brand names. Will absorb or be gone in about 2 months, assuming that we don't have any other factors that change that. Suture like PDS or polydioxanone is the generic name, will be gone for sure in about 6 months. So we might, let's say, in the average spay use a monocryl type suture because we don't anticipate any trouble with healing. But when we get to maybe a pyometra, where the patient's got an infection and she may be sick and her immune system may be busy, healing may take longer. So we may want to use something like the PDS because we know that it's going to last longer and give her body a chance to catch up there. PDS is something like 4 times more expensive than monocryl, so that would be why we don't use it for everybody, as well as the fact that then we're going to leave something behind maybe longer than it needs to be in a patient that's otherwise healthy. So synthetic absorbable multifilaments, as I mentioned, are often coming with some kind of an antibacterial coating on the outside because they do tend to wick bacteria. These are not very commonly used in abdominal surgeries. It's not wrong to do so. It's a lot more popular in Europe. But because of that coating in particular, we do see sometimes more inflammatory responses like especially for cats. We see a lot of things like incisional issues or redness with these bacterial coatings. They are very useful for things like dental procedures because let's say I'm suturing gum tissue, the knots will actually hold to themselves rather than cutting through that gingival tissue like a guillotine. So Vicryl being the brand name, or polyglactin's probably the most common one, and these synthetic absorbable multifilaments are almost always purple. Natural absorbable multifilament suture. The most common type is surgical gut, sometimes called catgut or chromic gut. This is made from that serosal layer of the intestine in some of our large animals, and rather than braid it, they sort of twist it. So this is essentially beef jerky, and for that reason, to stay pliable, it does have to be kept moist. So you may see it either individually packaged with an alcohol kind of liquid preservative solution, or sometimes on a reel, which is a cartridge where we just pull a length of suture from it at a time to use it, and that will have some kind of moisture inside, or else this becomes very brittle. Because it does have to be kept in a moist environment, this is a good choice for body cavities potentially, but doesn't do well for external sutures. Sometimes it's still used that way, but it doesn't necessarily hold as well because it dries out. It's very inexpensive, and for a long time it was the mainstay of suture for veterinary medicine, but as I mentioned, these natural sutures cause more inflammation, and for that reason we've moved away from them for the time being. You may still see it used in practices that have older practitioners or high volume practices and shelters where they're very concerned about the cost of suture, and for the most part it will work just fine as long as we use aseptic techniques. Now, non-absorbable multifilament, as we said, non-absorbable sutures are usually used externally for things like drain placement. Nylon is the most common, and it's essentially just fishing line. It's plastic, and so the body basically ignores it and is not able to break it down well. So we're only going to place this if we know that we're going to remove it in places like skin. It wouldn't be a good choice in places like the body wall, because it may cause irritation even after the tissue has actually healed. So we don't want to put it anywhere we can't take it out, with the exception of things like the very special suture that we use for certain orthopedic procedures. Metallic has one use only that I've seen of. Stainless steel is the only metallic suture I'm aware of in veterinary medicine. It is a very fine wire, so you're not really tying knots, you're bending it, and for that reason it can be pretty hard for the doctors to learn to use. It doesn't hold the knots well, and so if they don't use good technique with this, they can see a lot of problems with incisions. So they do sometimes use this in shelters to close the body wall for something like a spay, because it will never go away. It's non-absorbable, and therefore they'll always be able to palpate it later on. So this would be in lieu of something like a tattoo. The issue that I see sometimes with this is even years down the road, we'll see the little ends of the suture poke through the skin and cause little pustules or irritation because it's just a metal wire hanging out there. I don't think it's particularly painful, but we have had cases where we have to go back and remove it because it's causing irritation. Non-absorbable multifilament is silk, as an example. Silk is made by a natural source. It's made by silkworms, and then it's braided into these multifilaments. And technically, it's not going to last forever. It's not plastic, but it lasts for such a long period of time, greater than 60 days, before it starts to break down at all, that it's considered non-absorbable. Now, silk is very expensive compared to our synthetic materials that we can get a hold of, but the advantage is that for its diameter, it's much stronger. So if I'm using 5/0 or 6/0 suture, say in something like the eye, or working with very small blood vessels, doing a transplant, then silk is going to give me more bang for my buck. And so that's when you may see this used in practice. Lastly, we're going to look at suture patterns. Any of these suture materials can be used with any of these patterns, so the decision is going to be made on the type of closure we're doing, on the amount of tension on that wound, also what the practitioner is comfortable with. So looking at suture patterns, they're put into broad categorizations by how they bring the two sides of the tissue together. So we've talked about appositional healing, where the two sides come together just kind of straight at one another. There are inverting suture patterns that bring the edges down towards the body cavity, and everting patterns where they push up and away, kind of like two plates forming a mountain in, the tectonic plates of the earth. So we'll make different choices on that basis. We're also going to see that some of these patterns are what they call tension relieving. So if I'm in an area of the body that's going to undergo a lot of motion, those are going to be more appropriate choices. Now, when we close the patient after an abdominal surgery, so I make my spay incision or gastrotomy or whatever I'm doing, there's a few layers that we're closing. So we're always going to grab the connective tissue that attaches to the rectus muscle. If we made an incision in our abdomen, there's two rectus muscles that run cranial to caudal, and they come together in the middle at a spot we call the linea alba. And the linea alba is an aponeurosis. It's a place where the connective tissue of two muscles meet. And in that spot, we can put suture that will help hold the abdominal contents in. So that's the most important layer of suture. We're then going to get the subcu tissue, so that's going to be the other fascia and possibly kind of some fat in that process, and close that. And then finally we'll close the skin. So in this image we've kind of grabbed all of those at once, but oftentimes we may grab layers separately. It's important that we do get all three of those layers though. So we need that linea alba closure, that connective tissue actually holding the organs inside the body. Sometimes we just call that the body wall. We need the subcutaneous layer, those connective tissues like the dermis and the fascia on the muscle, so hold that layer in place, and then we'll need something, sometimes it's surgical adhesive, to hold the skin closed as well. Now there's two basic types of suture patterns, either continuous or interrupted patterns. Continuous, we're going to make one knot, and then we're going to suture all the way down the incision and then make a knot on the other end. The helpful part about these is we get really even tension as we go, because there's really only two knots. So it's not as if part of it has different tension than the other part. It'll all basically be the same. We don't use a lot of suture this way because we're not continuously stopping and tying a knot and cutting. The disadvantage here is if it breaks, potentially the patient can pull out the entire line of suture, so we don't have backups, as it were. And also potentially bacteria can use this as a pathway to kind of penetrate the tissues, because it does follow one path through the entirety of the incision. Interrupted suture patterns are our other option. In this case, we are going to take a while to be able to tie all these individual knots, and we use a lot more suture in the process. But theoretically, if one of those sutures breaks or the patient removes it, we've got backups in place, and this should also hopefully reduce the travel of bacteria. So we may make the decision on which pattern to use based on what situation we're dealing with. For instance, it's more common in something like an enterotomy, where I've cut into the intestine, to use an interrupted suture pattern, because I'm really worried about there being leaks of those intestinal contents into the abdomen. Whereas with something like the subcu space, I might use a continuous pattern, because I've got the body wall sutures in place, and maybe I've got skin sutures, and I've got other backups there, so it may be more efficient to use that continuous pattern and not use so much suture and keep the anesthetic on for quite as long. So the first pattern we'll practice in class will be the simple continuous pattern, and this is kind of how I sew, being someone who doesn't know how to sew. I'm going to tie a knot at one end, I'm going to pass at a diagonal through the tissue multiple times, and then I'll tie a knot at the other end, and that's all this is. So very fast, again, might be useful for things like the subcu space or even the skin to give me a really quick closure. and I just have to consider whether there's any disadvantage to the continuous pattern that may be an issue for me. One of the things I do see with this suture pattern sometimes is if we pull it too tight, it can cut through the tissues or be kind of uncomfortable, so that would be one issue to consider. If there were inflammation or swelling, this pattern isn't very good at handling that without just kind of guillotining through the tissue. Next, we've got the simple interrupted pattern, and this is going to be I just pass through the tissue, tie a knot, and cut everything. Pass through the tissue, tie a knot, and cut. So very basic. This is the type of thing, as I said, we use in organs a lot of the time. If I do a cystotomy and remove bladder stones and I want to be absolutely sure everything's going to stay, I'm going to tie a lot of little knots to accomplish that. So this works well for that, but it does take a long time and it does use a lot of suture. The next pattern is the continuous forward interlocking. So this is, as it states, a continuous pattern. I tie one knot and then I pass through the tissue, and when I do that, I catch some of the additional tissue. And the net effect of that is that the tension on the incision is moved off to the side. We said the simple continuous pattern, the suture kind of cuts across that incision line, but with this situation, we see it's kind of moved to one side of the tissue. So I've seen this used in situations, I had one where the dog had its ear chewed off, and they came in and they wanted us to reattach the ear, and we couldn't do that, but we needed to go ahead and close the pinna, the exposed tissue of the ear. And if I just used a pattern that kind of cuts over top of the pinna, that would have been painful for the patient because that cartilage is exposed and the nerves there, and so I needed a suture pattern that was offset a little from just over top of the top of the ear that had been damaged or chewed off there. And so the forward interlocking pattern was chosen by the doctor in that situation so that the tension was moved to further down on the ear where the tissue was intact. Now, an interrupted cruciate pattern is our first example of a tension relieving pattern. So that means if I have an area with not enough skin available and I'm just trying to pull things closed, or an area that's going to be, let's say, on a leg that's moving a lot, the suture is going to hold better without cutting through the tissue than if I use like a simple continuous or simple interrupted pattern. So it spreads the tension out, so I'm not just pulling on one spot and I'm not just going to tear this out, let's say, when I move my leg, because it's going to allow that tension or that force to be distributed a little bit better. So these are called cruciates because they are X's, just like the two cruciate ligaments in your knee form an X. And it is an interrupted pattern because we make one X, we tie it off and we cut it, and then we go on to the next one. Now, both of these mattress patterns have similar indications. They are both tension relieving, and these mattress patterns are very useful in situations where we're going to be, let's say, not able to completely oppose the tissue layers. So we may have to just pull the skin as close as we can to the other side, but they may not be touching. And you can do that with horizontal mattress or vertical mattress patterns without tearing through the tissue because they offset that tension or that pull to one side of the incision. And so that's when these are going to be used. Again, they take more time. They're both interrupted patterns. They take more suture, but if you don't have any other option, these are a good choice to keep the incision as closed as possible if you're going, let's say, for something like third intention healing eventually. There's not any particular indication for the vertical mattress over the horizontal. When we practice in class, you'll see the difference is simply the direction that I insert my needle. They both have the same indications. So as far as suture removal goes, we're going to remove them in 10 to 14 days after surgery. We do want to grasp the knot with our thumb forceps or another instrument and make a cut next to the knot. And the reason that we do that as opposed to somewhere else is it helps me ensure that I don't leave any pieces of suture behind. We're going to use those suture removal scissors that have that extra little hook, and I'll include a video in the playlist for you to watch that goes over that technique as well. Now the knots that we tie for suturing are different than what you might tie for your shoelace, and the reason they're different is that we need to have them hold in place despite obviously all the pull on the suture there. So we're going to work in class on tying a square knot, and a square knot allows us to keep the tension in multiple directions. So it'll make more sense when we practice it, but with a square knot, we're going to pull left to right with our first pass, and then we're going to pull right to left with our second pass. And that makes it harder for the suture to come untied in that process. A surgeon's knot does the same thing. So the first time we pull the suture ends left and right, the next time we pull them right and left, so they flip over one another, but we may wrap them around a few more times, just give us a little extra hold. There are many, many, many different kinds of knots that are used. These are the basic ones that are used for almost every pattern, but sometimes you'll hear others. It just depends on where the doctor did their surgical training, where they went to school, what their preference is. There's not necessarily an indication for one knot over another. And when we talk about a throw is just one of those ties. So every procedure is going to be different in terms of the number of throws, and every doctor is too. So maybe one doctor ties something 4 times, that would be 4 throws. Maybe another doctor ties the same neuter procedure 6 times. It might depend on their level of comfort with that suture material, or maybe one dog has a bigger blood vessel, so they feel like they need more throws. But there's not necessarily a direct relationship between the number of throws and how strong or how well that knot holds. There is a direct relationship, though, to whether or not we do a good job with our technique. So we'll practice that in class. So finally, we've got our complications here. What can happen that is bad? As I mentioned before, we can see inflammation or irritation as a result of the suture, even if there's not contamination. Sometimes the body just treats it like a pathogen, and we'll see instead of healing, we get an infection, or we get a body that just will not ignore the suture, so they get kind of stuck in that lag phase. So that would fall under host rejection. That, like I said, is more common with cats, and especially with suture material that has a coating of some kind on it. In those situations, we will go ahead and do another procedure, take the suture out and replace it with something else. Now, what we worry about the most is dehiscence. So if I have an area that's sutured where I have too much tension, or the patient just chews the sutures out, then I can see that my incision comes open, and we refer to that as dehiscence. So dehiscence can happen because we did something wrong, we used a bad pattern, we closed something that had too much tension, we cut our suture or didn't tie our knots well, or dehiscence can happen because of trauma the patient does after the fact.